A warm welcome, dear students. I'm Dr. Pratyusha. After extensively learning about chronic suppurative otitis media, both the atticoantral type as well as the tubotympanic type, now let us learn the complications of CSOM. Okay? Complications of CSOM are extremely important both in the clinical practice as well as from the exam point of view. Now, first of all, we need to clearly understand what exactly is a complication and what is just a sequelae of otitis media. As long as the disease process is confined to the middle ear cleft, to the 6 boundaries of middle ear, we call it chronic suppurative otitis media. When it extends beyond the bony walls, when it breaks the bony walls, then we call it complication. Now, for example, ossicular chain necrosis. Is that a complication or a sequelae? It is well within the limits of the middle ear cleft, so it is just a sequelae. Labyrinthitis, is it a sequelae or a complication? It is a complication because the infection is progressing from middle ear into the inner ear. It is penetrating the medial wall, causing bony destruction and going into the labyrinth. So please understand this distinction carefully, and in this video we are going to look into the complications of chronic suppurative otitis media. I told you bony destruction is very important. How does bony destruction occur? Bony destruction can occur in both ASOM as well as CSOM. Now, these are the complications for suppurative otitis media, both for acute as well as chronic. Complications can occur in either of the conditions. Okay. So, in ASOM, the bone is destroyed by a process known as hyperemic decalcification. In CSOM, or in cholesteatoma, basically the atticoantral type of CSOM. How does cholesteatoma destroy bones? We have already learnt about this. By bioenzymatic degradation, it will activate osteoclasts. It will release various inflammatory mediators. All in all, the bone is destroyed. Now, in the pre-antibiotic era, complications of suppurative otitis media were very common, and they were fatal also. They were life-threatening. A small otitis media could result in meningitis, it could result in a brain abscess, and it could even cause the death of the person. They were that fatal. But with the advent of antibiotics, this condition has largely been addressed. But still, the problem today is many patients are not aware that a middle ear infection is a potentially dangerous condition. They just think that the ear is discharging and it's okay, let it go on like that, it will resolve by itself. Unless and until there is excruciating pain, they do not turn up to the doctor. They try to perform certain home remedies and get away with it. Mostly because they are unaware that an unaddressed middle ear infection could lead to fatal complications, including intracranial complications. So this is the reason awareness is important from the patient's side. And when a patient presents to us as doctors, please remember that any case of otitis media can end up in complications and be mindful of the complications. So let us learn about the complications and certain general factors related to complications. In whom do complications arise, first of all? What are the factors responsible for complications? Number 1 is age. Extremes of age. Childhood, in the first decade of life, as well as in very elderly people, they're more prone for complications. Why? Because of poor immune function, poor resistance. Next, poor socio-economic group. Why are these people prone? Because of poor hygienic conditions, poor nutrition, lack of health facilities, lack of health education. All these factors make them prone. Next is virulence of the organism. The organism that is causing, if it is very virulent, it can lead to complications. What do I mean by virulence? One type of virulence is producing degrading enzymes. Another type is the microorganism becoming antibiotic resistant. These days we have a lot of antibiotic resistant strains. So when there is an antibiotic resistant strain, the medications that we give do not repeat. So when there is an antibiotic resistant strain, the medications prescribed are insufficient to completely resolve the infection. So there is some latent subclinical infection that is left out inside, and that can lead to intracranial or intratemporal complications later on. Next is immunocompromised host. Who is an immunocompromised host? Uncontrolled diabetic patient, patients of organ transplantation who are on immunosuppressive drugs, cancer patients, HIV positive patients, all of them are poor immunized status patients, immunocompromised patients, and in them in general any infection can thrive. Next we have poorly pneumatized temporal bone, which acts as a factor. If the temporal bone is not well pneumatized, it can easily give in to infections. Preformed pathways. Apart from the normal pathway, for example, if there is some dehiscence of the bony canal of facial nerve, that makes it easy for the infection to spread, isn't it? So if there is any preformed pathway for the spread of infection, that can make the person prone to complications. Last on our list is cholesteatoma. We already know that cholesteatoma is an unsafe or dangerous type of CSOM because of all the complications that it can lead to. Cholesteatoma is associated with osteitis and granulation tissue, and these destroy the bone and they help in the spread of infection. They make the infection penetrate deeper and deeper. So these are certain factors that make a patient susceptible to complications. Now let us look into the various pathways of spread. How is the infection exactly spreading and where is it going? So broadly, there are three routes through which the infection spreads. First is bone erosion. This is the most common route of spread. We already discussed that in ASOM, bone erosion can occur by hyperemic decalcification, and in cholesteatoma, it can occur by enzymatic degradation. So the middle ear infection will result in destruction of bones, and once the bone is destroyed, the infection very easily spreads on to the next compartment. Next, the other pathway that we have is progressive repeat. Next, the other pathway that we have is progressive retrograde thrombophlebitis of small venules. The infection can spread via veins. Now, if you remember, the veins present within the temporal bone, they have a direct communication with the intracranial diploic veins. They have connections with the extracranial veins, intracranial veins, as well as the cranial diploic veins. Now, the Haversian canal veins within the cortex of the temporal bone, repeat. Now, the Haversian canal veins within the temporal bone, they communicate with the intracranial dural venous sinuses. They also communicate with the superficial veins of the brain. And this way, the mastoid bone infection can result in thrombophlebitis of the venous sinuses. It can even lead to sigmoid sinus thrombosis, cortical vein thrombosis. All these are complications, right? And if this is the mode of spread, you will observe that the bony walls are found intact. The bones are not eroded. It is through the veins that the infection is spreading. And this pathway is more so seen when acute infection results in complications, because this is the fastest route. All right. So how is it happening? Haversian canal veins are directly communicating with extracranial, intracranial, as well as diploic veins. This is the second route. And the last route is preformed pathways. We have already discussed that if there are preformed pathways, it makes the patient prone for complications. Now, how can preformed pathways be present? One is if there is a congenital dehiscence. For example, as I told you earlier, a dehiscence in the bony canal of facial nerve. We call it the fallopian facial canal. If there is a congenital dehiscence there, or in the floor of the hypotympanon, we know that it is just a small thin plate of bone that separates the middle ear from the jugular bulb. If that thin plate of bone is dehiscent, that can easily lead to the spread of infection downwards. So here we have, one is congenital dehiscence. This is one possibility. The second possibility is sometimes certain sutures remain patent even in adult life. Patent sutures. What do I mean by sutures? The joints of the skull, for example, the petrosquamous suture. The suture fuses at a certain age, but for example, it remains patent. It can serve as a route for infection, isn't it? Then in temporal bone fractures, whenever a fracture heals, it is mostly the fibrotic tissue that is present there. It is the fibrous scar tissue which is at any day not as tensile or as strong as the original tissue present. So this can also permit the spread of infection. What are the other preformed defects that are possible? Repeat. What are the other preformed pathways that are possible? Surgical defects. For example, a stapedectomy has been performed, or a stapedotomy has been performed, or some mastoidectomy surgery that has exposed the dura. That will also leave a channel, a communication channel for spread of infection. Perilymph fistula. This is another preformed pathway. And then infection from the labyrinth, it can travel along the internal acoustic meatus, along the aqueduct of the vestibule, and then into the cochlea, and then it can spread to meninges. This is not exactly a preformed pathway. It is a natural pathway that can sometimes serve as a route. See, even certain normal anatomic pathways also can act as routes of spread. What are some of the natural normal anatomic pathways openings that can serve as a route of spread? the oval window, round window, internal acoustic meatus, cochlear, aqueduct, endolymphatic duct, all of them. Okay. So let us summarize where all does the infection go and what does it lead to. If this is your middle ear, the infection can go by various routes, right? If it goes via the roof, disrupting the tegmen tympani, what all can it cause? It can cause an extradural abscess, subdural abscess, basically abscesses in the brain and meninges. And it can cause meningitis, brain abscess, cerebellar abscess, it can even cause a condition called as otitic hydrocephalus. We will learn about it in more detail while learning the complications. All this via the roof. Now, if the infection spreads via the floor, then it can cause thrombosis of the jugular bulb. What is the closest structure to the floor? It is the jugular bulb, right? So, thrombosis of jugular bulb can occur. If it spreads via the floor. Where else can it go? It can go in the posterior direction. What all do we have in the posterior direction? Mastoids, right? So, if it goes posteriorly, it can cause acute mastoiditis. It can cause lateral sinus thrombosis, facial nerve palsy. It can traverse via the Trotman's triangle and cause a cerebellar abscess. It can traverse via the solid angle and it can cause superior petrosal sinus thrombosis also. These are the various complications that can occur if the infection propagates in the posterior direction. What else do we have? Anteriorly, there is just the eustachian tube opening. If it goes laterally, there is the tympanic membrane. It can perforate the tympanic membrane and come out. And also it can cause otitis externa sometimes. But these are not very important. If it goes into the medial direction, if it goes into medial direction, it can cause labyrinthitis. So these are various complications depending upon the route of spread. Now we can classify all the complications under 3 headings. We can study them in 3 groups. First being intratemporal, within the confines of the temporal bone. What are the complications seen here? First is a persistent tympanic membrane perforation. Now we all know that the tympanic membrane could perforate in ASOM, but later on if it's a small perforation, it heals by itself. In case if it persists, then it is said to be a complication. Then of course mastoiditis is a very important complication. We will study in detail about mastoiditis. Then acute petrositis. Then we have facial paralysis, labyrinthitis. Certain fistulas can occur, labyrinthine fistula. This is the first group. The second group, extratemporal. Under extratemporal, we have various abscesses. Okay, all the abscesses are put here. Post-auricular abscess. It is the most common abscess. Zygomatic abscess, Bezold's abscess. Citylis abscess. Lux abscess. There are various abscesses like that, even parapharyngeal and retropharyngeal abscesses. All of these have been discussed under eponyms of ear also. In the video eponyms of ear, all these abscesses were discussed. Then finally we have the most fatal and dangerous ones, the intracranial complications. What are the intracranial complications? Extradural abscess, subdural abscess, meningitis, CSF otorrhea, lateral sinus thrombophlebitis, what else do you have? Intracranial complications. A brain abscess can occur. And finally, even otitic hydrocephalus. So these are the various complications that are possible: intratemporal, extratemporal, and intracranial. So far we have discussed broadly about complications. What exactly is a complication? What are the factors that predispose a patient towards complications? What are the various routes of spread of infection? And finally, the list of complications. In the next videos to come, let us learn in detail about most of the complications that are important. Thank you very much.